consultations.
Hello and welcome to La Vida Library. A little house note, the restrooms are at the bottom of the stairs and there's a water fountain down there too. We do have hot tea and homemade cookies by Sarah back here. And also, they graciously brought some Trader Joe's, which we don't get in La Vida. So here's your chance to have a little Trader Joe's buffet. Upcoming events, library events tonight, we have Taylor Swift Music Bingo. If you're a Taylor Swift fan or know someone who is, that is at 6 o'clock at Mountain Merman Brewing Company. We do not have a normal Thursday program next week because we're involved in the Halloween events at the school. But the week after, Becky Myers, she's done several art programs for us, is back doing a Dias de los Muertos program on art and culture. So that'll be exciting. Same time, 2 o'clock that Thursday, November 6th. So today we've got End of Life Options Colorado. John Davidson organized this and made this connection for us, so thank you very much. This is a very important subject to bring to light here, and with that I will turn it over to the variety of speakers. Oh, one more thing, we are recording, so if you do need to get up for any reason, just be aware there is a camera recording in the back. Thank you.
I'm just going to, hi, I'm Aurora. I'm like here to play, whatever, a moderator. Dr. Wolhoit is going to do a fabulous presentation, and then after that we'll have a little panel and open it up. If you have a question you would like to ask, please raise your hand and I will bring you a card to write it down on, and then we'll put it to the panel after the presentation. So just as you're inspired, let me. Okay, sorry, thank you.
Well, I was asked to use a microphone today, and so please, if I start to wander from the microphone or I start to speak too fast, or for any reason you just need me to kind of just pause and say, what was that? Don't hesitate. My name is Susan Wilhoit. I'll get to my introduction here in a moment, but really what I hope for today is that this becomes, if it feels right, a conversation. So moving right into this, what are hopes? Here we are in this beautiful town. Thank you all so much for having us. The drive-in was gorgeous. So this is my first time here, and I felt really lucky to get to be here. So thank you all. So we'll go over introductions and go over some abbreviations. No talk of anything in medicine is without abbreviations. I want to help folks understand what to consider when they're facing serious illness or life-limiting disease, and certainly terminal illness. And I think probably the reason why most folks are here today is to really understand the options around choosing a death that's right for you when you're terminally ill. And thankfully, here in Colorado, we do have access to the Colorado End of Life Options Act, which we're really going to get into the bulk of today. The most of our time today is going to be spent looking at the Colorado End of Life Options Act and what that means here in our state and how it might apply to you. But ultimately, we want to empower you. We want to educate you. We want to share stories. And we really just want this to be an experience where you leave feeling like you have a little bit more understanding about maybe what you might want for your death. And I think oftentimes what I've learned is when that happens, we often think about how we want to live too. So I think that I hope today you guys leave here feeling just a little bit more empowered to live the life that's best for you. First, before anything else, I'd like to just start by taking a moment and acknowledging that death is hard. Loss is hard. There's grief. There's all of the complications that can lead up to a death, and complications after we've lost someone that we love. The conversation that we have today is going to be talking certainly about death and maybe taboo aspects of death, I'm not sure. So I just want to pause and thank you all so much for taking the time and the courage and the vulnerability to show up today. And I also want to thank, for me, the people that I've learned from. I continue to learn all of the time from my patients, from their families, their loved ones, and it's really their inspiration and how they choose to live their lives and how they choose their deaths that I find so meaningful. And so I want to say thank you to them and thank you to all of you. So I am a volunteer with End of Life Options Colorado, which is our statewide nonprofit organization really focusing on helping people understand what their options are around their end-of-life choices. So at End of Life Options Colorado, you can go to their website and be connected to individuals within the organization that can help you understand what your options could be, how to access certain aspects of the law, for example, and also just how to find resources around end-of-life work. So again, I'm Susan. I am a palliative medicine and hospice physician by training. Most of my career has been in the palliative medicine world and hospice work. I have my own practice now, actually, where I work with folks from all over the state of Colorado, and it's called Rocky Mountain Compassionate Care. Throughout our presentation, you'll see some QR codes. If you want to take a picture of it, or feel free to snap a photo if it's easy. But that's how you can access the website. Please. Oh, we also have information over here. Thank you. Thank you so much, Aurora. Right over here on our front table, we do have resources for End of Life Options Colorado. And also a sign-up sheet if you're at all interested in signing up for emails. I also, as a part of my end-of-life practice, I do ketamine-assisted therapy for individuals who are facing serious illness. I also am a certified death doula, or end-of-life doula, and I just find, for me, and we can talk a little bit more about doulas later, but I really feel that the doula work, in terms of just being this extra layer of support for individuals and their loved ones when they're facing their end-of-life experience, for me, as a doula and as a physician, I get to really be alongside patients and their families in ways that I find really meaningful, and I'm really honored to get to do that piece of my work. But I'm also a stepmom and a dog mom and a cat mom and a wife. These are my loves. So abbreviations, and I think everybody's probably going to know EOL, maybe. You can just shout it out. Thank you. Yes, thank you. Shout it out. Okay, next, end of life. We got that. What's next? End of ELOA. This might be a little trickier.
Options
Yeah.
available.
Oh, so close. I love it. Thank you, John. Thank you for trying. And it's End of Life Options Act. So really, it's the act that we'll all learn about. It passed in 2016, enacted in 2017, that allows us to use medical aid in dying here in Colorado. Medical aid in dying, I give it away. Sorry, fast fingers. So MAID. MAID is the colloquial term. That's how a lot of folks refer to medical aid in dying. You'll hear people say, oh, I'm going to do MAID. I'm thinking about MAID. And you're like, why are you worried about your house right now and cleaning? You need to focus on other things. But it's medical aid in dying. And VSED, does anybody know that term or that acronym? And it's okay if you don't, because we're going to talk about it. All right. It is the voluntary stopping of eating and drinking. And we'll get into that in a bit more. So I first want to just name what I mean when I say a life-limiting illness. Life-limiting illness, you'll hear the words life-limiting illness, serious illness. Really, that's going to be when somebody has been diagnosed with a disease from which they are likely going to die, and possibly earlier than it would have ever been hoped in terms of their life trajectory. So we think about a serious illness, doesn't mean that they're dying right now, but their life is going to be limited by this illness. And of course, unfortunately, the disease is going to progress, and we're going to then talk about terminal illness. So terminal illness, I'm distinguishing here the difference between a serious or life-limiting illness and a terminal illness. So the terminal illness is once that serious or life-limiting condition has reached a point where the person's prognosis is 6 months or less. So this graph is going to get a little busy here in a second. But generally speaking, when someone has been diagnosed with a life-limiting illness, most of their time upon initial diagnosis, maybe even sometimes for years afterwards, maybe, you're focusing on the disease. So the intention around treatment might be curative, might be focusing on really sustaining life at any cost. You're really trying to target the disease. And unfortunately, a lot of these illnesses are going to come with symptom burden. And also, their treatments themselves might have symptom burden. So I think the best example there is chemotherapy. While chemotherapy can be a disease-targeted or possibly even curative intervention, chemotherapy is not without symptom burden. And so palliative care comes around to really try to support people who are in some sort of treatment for a life-limiting or serious illness. And the palliative care can overlap with their curative or life-sustaining care so that they can focus on comfort, quality of life, managing symptoms, whether they're related to the disease or to the treatment itself. Sorry guys, it's my first time using this button, apparently. Okay, here we go, there we go. So, over time, again, thinking about disease progression, there will become a time when the idea of focusing on the disease and curative measures, maybe there aren't any more options. Maybe there are no more treatment options. Maybe you've exhausted all other aspects of potential curative measures. Or maybe for some people they say, look, I don't want these anymore. I don't want to keep doing this to myself. I need to focus on my comfort solely. I don't want to keep pursuing curative intention. And that's when it's really important to get hospice involved. So hospice is going to be your expert in symptom management, again, emphasizing, just like with palliative care, but with palliative care, of course, you're having that overlap of disease management with your palliative interventions. Whereas hospice, you can say, I'm going to focus solely on my comfort and on my quality of life. The benefit of hospice, too, is not just for the individual who is dying. Hospice can do so much for the families and the loved ones of those who are dying, and after the person has died, hospice allows for 13 months of bereavement support after the patient's death. So I just wanted to, again, define kind of what we talk about when we say serious illness and life-limiting illness versus terminal. Again, we think about serious illness kind of in this box. Oh, I'm going to try this. I'm trying new things today, microphones and lasers. Oh,
Nice.
So with the serious illness, we're really focusing on the folks that are getting disease management, hopefully in some palliative care as well. And when people are in that phase we were just looking at, and they want to think about what their options are, because this talk obviously is about options, you can say, I want to focus on all of these disease-focused interventions, let's keep going, and that's okay. As long as it's been offered and that's what's right for you, do it. It's what's right for you. You can also say, no, I'm done, please stop. Or just limit, like maybe we could try this, but I don't want to do this anymore, and that's okay too. And of course, with all of this, I would always encourage folks to please engage in palliative care to have that extra support around symptoms and quality of life as you're trying to focus on your disease management. So when we look at terminal illness, again, that's when somebody has that prognosis of 6 months or less. That's going to be really key as we think about what the end-of-life options are in that 6 months or less prognosis phase. So here in Colorado, we have 2 options for patient-directed, meaning the patient gets to decide and really curate the death that's right for them when they're facing a terminal illness, when they have that prognosis of 6 months or less. In Colorado, people, and actually throughout the United States, VSED is available. So the voluntary stopping of eating and drinking, as well as medical aid in dying. I want to have a quick plug here, because regardless of what option, or any option, if you don't choose any, that's also an option, not choosing any of those is also okay. Regardless, I encourage anyone that's facing a terminal illness to please consider enrolling in hospice, and please do so sooner rather than later. Early hospice enrollment, meaning as soon as you've been told, hey, I'm really worried, I think that you're not likely going to survive very many more months, more weeks, hopefully not days, although unfortunately the average hospice, the average time someone's on hospice is less than 2 weeks. The reality is, the longer, the sooner you can get connected to your hospice team, the sooner you can build relationships, the sooner they can get to know you, the sooner they can also say to your family, hey, I'm noticing these changes, and I think we need to have a conversation. And all of that is part of the benefit to me of a hospice team. Again, they're going to be the experts in symptom management. Going back to the cancer analogy before, chemotherapy, absolutely go to the oncologist. If you have cancer and you want chemotherapy or immunotherapy or disease-targeted care, that oncologist is going to have all of the expertise on how to manage your cancer. The hospice team, the hospice physicians, nurses, social workers, chaplains, the team, they're going to be the experts in understanding how to manage symptoms, more so than the physicians that are otherwise managing the disease. The beautiful thing about hospice is that it's a team. So you have, just like with end-of-life experiences, it's not just your body that's dying, it's that maybe you have to get your finances in order, and that emotionally it's incredibly stressful. And spiritually, maybe you're feeling some angst. Maybe you have little ones, like grandchildren, children, that you don't really know how to talk to them about this disease. Hospice can help with all of that. So it's this interdisciplinary team that comes in and is intended to wrap around you, the patient, and your loved ones to make what is going to be a very difficult process. Because as we said in the beginning, death is hard, death is sad. But your hospice team can make that maybe just a little bit better. And again, I did mention, I will say, I have a lot of folks I've worked with over the years that maybe I'm working with them in the palliative care setting, so and I'm the one trying to, having to tell them that their diagnosis is now terminal, their prognosis is now terminal, and I'm encouraging them to please consider enrolling in hospice. And a lot of folks say, oh, no, I'm not ready for that yet. I'm not ready for that yet. I don't want to do that. And I explained that, well, would it be okay if the care came to your house? Well, yeah, that could be good. I don't want to go to the hospital anymore, the doctor anymore. Okay. Are you concerned at all for your family? Well, yes, I'm very concerned. Okay, so they could help with that too. What about after you die? Do you have any worries that your family might grieve or might have some struggles with your loss? Yes, most people say. And so then I say, okay, well, hospice actually can support with all those things you just voiced to me that you're concerned about. So we don't have to call it hospice if you don't want to. Some people have a problem with the H word. But think of it as a way of caring for your family. And especially for a lot of my older patients, the idea of caring for their family lands a lot better than the idea of them receiving care. Because that bereavement support really can be helpful for those 13 months after someone's died. It's covered by Medicare, Part A for now. So enroll as soon as possible. I also want to say, I think hopefully it goes without saying that at End of Life Options Colorado and in my own personal practice at Rocky Mountain Compassionate Care, I have no agenda. End of Life Options has no agenda other than all of us want to empower and educate folks as they consider their end of life options. We're not here to push any one option or tell you what's right or wrong for you. I think what's most right for you is what's right for you. And that's what we're here to talk about today. I do want to check in. How is the mic working out? Okay. Talk louder? Okay. Let me see. Yeah. Is that better? Oh, thank you. That seems better to me. Thank you for speaking out. Thank you. Awesome. Okay, good. Well, I'll start over again. Just kidding. All right. So VSET, I mentioned this at the very beginning of this abbreviation slides. It's this deliberate, so someone has chosen, knowingly, cognitively chosen to, on their own, not because of anyone else, but on their own, initiated their own dying process by foregoing all hydration and nutrition. So whether it's food by mouth and drinking by mouth, or fluids that come into the body intravenously, it is a way of hastening an anticipated death if someone wants to control the manner and timing of their death. I actually have a whole other talk I give on VSET, because it deserves a whole hour, at least in and of itself. Today, really focusing on MAID, medical aid in dying. Like VSET, it's an option people have who want to control the timing of their death. And it's available here in Colorado, thanks to the End of Life Options Act. So as we think about facing a serious illness or life-limiting disease, or being told we're in a terminal stage, you can always continue medical treatments if they're offered, stop or reduce them. Please always consider getting palliative care involved. Always, when it's eligible to you, hospice, please. And if you're someone that wants to consider controlling the timing of their death, look at VSET or MAID. As you approach any of these things, you want to think about what matters to you. Because at the end of the day, all of this is about you. So, 2016, the Colorado End of Life Options passed here in our state, thankfully, and then January 1 of 2017, it became available. We were able to access it and support patients with this option. And in 2024, just last year, there's an update. So this will make more sense once we go through the process later, but there is a waiting period that people have to go through, and previously it was 15 days, and that was it, 15 days, no exceptions, no matter what, and the only prescribers in Colorado that were allowed to participate were physicians, so MDs and DOs. And now, thankfully, that waiting period has been reduced to 7 days, and we have the option to waive the 7 days and decrease it to 48 hours between the requests. So that way, if someone is actively dying or we're really concerned they're not going to make it to 7 days, then we can say, look, we need to expedite this and allow them to make their second request within 48 hours. And thankfully, to help with access, yes, Aurora here is a nurse practitioner, and as of 2024, nurse practitioners in Colorado can also participate. And that's a huge resource that we have.
Can I ask who you are asking to get this permission?
Yes. Good question. And we'll go through, yes.
Okay.
You're going to ask the attending physician 2 separate times. And we'll have the whole process. But yeah, there's a waiting period, which will make more sense. But thank you for asking that. In Colorado, again, just reiterating that this is what the Act does. It allows access to medical aid in dying. And, okay. Now let's look a little bit more closely at what is medical aid in dying. So this is a clinical practice, it's a medical practice, available in 11 states, 11 jurisdictions, so 10 states plus the District of Columbia, for adults who are terminally ill, that are able to make decisions on their own, have the capacity to choose their own medical care, who want to choose the timing and nature of their already anticipated death. And they do this by ingesting, on their own, independently, medications that are lethal, for which they're going to die.
Question. Medical power of attorney by a family member, is that included in this?
No. Great question. And I wish, next time when I come back, we'll do this again. We're going to play a game where the most common questions are going to be tallied up and we're having like a game show, because that's one of the most, like ding, 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 like that's one of the most common questions asked, is can your power of attorney pursue this on your behalf? And the answer is no. And we'll get into that a little bit more depth later, but thank you, that's a very common question. So medical aid is not available to children. It's not available to those who don't have the capacity to make their own complex medical decisions. It's not approved for someone whose terminal condition is a psychiatric diagnosis. It's not a pill. It's not one medication. It's not physician assisted. It's not euthanasia. And I'll pause there for a second. So physician assisted means that I, as the physician, am administering the medication to the patient. So all other countries where their own country's version of medical aid in dying is legal, uses injection through the IV. In the United States, not in any state where medical aid in dying is accessible, are we able to do that. Throughout the United States, anyone who's using medical aid in dying has to self-ingest, because we cannot have physician-assisted is illegal here in the United States. So physicians, nurse practitioners, no one can assist the person in their actual self-ingestion. Euthanasia is when someone else determines someone else is suffering. So, 2 years ago, I had to say goodbye to my sweet Lindy girl. Oh, my dog, she's amazing. It was very clear, to me, that Lindy was suffering. Lindy was no longer enjoying life. Lindy was no longer able to really take care of her needs. And it was really clear, this was more harm, it was causing her more harm. So I decided to call a wonderful, compassionate vet who came to the home, who assisted Lindy in her death by injecting medications. So that's when I made a decision for my animal. Euthanasia is, again, someone else has made the decision that someone else is suffering. If that makes sense. And by law, this is not suicide, and it's not murder. Thankfully, baked into the law, we have specific protections. So we just said, it says in the law, this is not mercy killing, this is not suicide, this is not euthanasia, this is not homicide. And I'll say one note about that. The idea of suicide, because oftentimes you'll hear this as physician-assisted suicide. Well, I think we all know now, it's not physician-assisted, we got that down. But if you look at the actual definition, if you want to really truly get out the dictionary here in the library and look up suicide and look at the etymology, the root origin of the word, you would see it's killing of the self. So sure, by definition, you could say that. In the United States, suicide is a legal definition, which has legal repercussions, meaning that your life insurance, for example, could be impacted if someone has completed suicide. That impacts their life insurance. With the medical aid in dying rights that we have here in Colorado, thanks to the End of Life Options Act, someone who chooses their death with medical aid in dying, their life insurance and anything else like financial repercussions, those do not exist, thanks to the law. And one of the most important protections that comes up a lot is the death certificate has no mention of medical aid in dying. It's the person's underlying terminal illness from which they were dying, period, and any other contributing health factors that they may have. But nothing about medical aid in dying, nothing about drug overdose, which ultimately, putting it bluntly, that's what it is, but there's no mention of that. The death certificate purely states this person was in hospice, this is the cause of death, and these are the contributing factors. Nothing with medical aid in dying. I always found this so helpful when I talk to folks about this, that medical aid in dying does not change the number of terminally ill people who are going to die of their disease. But the hope is it offers the terminally ill people who are dying of their disease more control. So, getting into the nitty-gritty of the eligibility. We have our definition here that we see on the left-hand side. We went over that. And then now let's kind of compare that to how the End of Life Options Act writes out or spells out the eligibility criteria here in Colorado. So we know we have to be an adult, older than 18 or older, and you have to be terminally ill, a prognosis of 6 months or less. You have to be able to make your own medical decisions. And you have to, and I should say, when I say that, you have to make your own medical decisions, or be able to make your own medical decisions at the time of going through this process. So it can't be, for example, a living will, a power of attorney, a surrogate, nothing. Only you, the person who is facing a terminal illness, can make the requests that we'll go over in a moment, but you have to be able to show that you have the cognitive capacity to make this decision for yourself. John?
Who makes that determination?
2 physicians, or two providers, so physicians or nurse practitioners.
And what is the criteria that they use?
We'll get into that. So I'm going to repeat the question. So John was asking me to call you John.
Yes, please.
So John was asking who makes this determination on assessing someone's capacity. So the person's going to go through basically, well, really 3 different clinical visits with 2 different clinicians. So with one twice and the other one just once. And on all of those visits, those clinicians are assessing it throughout the process the person's mental capacity. So I want to take a moment and go through cognitive capacity versus something like dementia, where you have cognitive impairment. So capacity is actually a medical definition. You think about competence. How many people are like, oh, he's not competent, he can't take care of himself? Anybody heard the competent used before? Yeah, I see some heads nodding. So competent is oftentimes used, you hear it on TV shows, I hear other doctors use it. Competence is a legal term, determined by a judge as to whether or not this person, and John, you're an attorney, is that right?
Yes.
So you can correct me too, please. Competence is determined by a judge whether or not this person is able to care for themselves or make decisions for themselves from a legal perspective. And is that fair?
Actually, New Mexico and I think also Colorado have moved from competency as a determination for guardian conservatorship or making will to capacity, which I think you're going to talk about.
Yes. So the big thank you. The big take home here is capacity. So capacity is the medical term, and capacity is relative to the situation and the person and what's being asked. So one of my examples is, let's say I have somebody who has moderate dementia. Okay, so not severe, not mild, but moderate dementia. And that morning, I asked them, what do you want for breakfast? And they said, well, I had Raisin Bran yesterday and I don't want that. And I don't really like the toast. But I think eggs. Actually, yeah, I'm really craving eggs this morning. I think I'm gonna do the eggs. So they have the capacity to make that decision about what they want to eat for breakfast. They were able to go through the options that they were presented, Raisin Bran, toast, or eggs, and they were able to say why they're choosing the eggs. And so that's really what capacity is. Do you know what you're being asked? Do you know what your options are around what you're being asked? Can you tell me the pros and cons of the options that you do have? And then can you tell me why you're choosing what you're choosing? That said, that same person with moderate dementia, moderate cognitive impairment will say, maybe later that afternoon, we have a big family meeting where we're talking about complex goals of care. Does this person want to be resuscitated? Do they want to be on IV fluids? And I'm asking the same person who earlier that day I talked to and was able to make the decision about their breakfast. Maybe that afternoon, we're talking about really pretty complex ideas, and they're not tracking, they're not following. So capacity can change based off of what is being asked. Capacity can also change during the day. So maybe that same person who could answer me about breakfast, by the time they get to dinner, the end of the day, they are just out and wiped, and they couldn't tell me what they want for dinner. They don't even know if they want dinner. What is dinner? And then tomorrow morning, they'll be able to choose breakfast again. There's waxing and wanings. So capacity is very situation dependent. So with medical aid and dying, that's one reason why you have really 3 different, at least, medical evaluations throughout the process to be able to determine this, does this person really have the capacity to be able to, on their own, without being coerced, without any pressure, purely on their own, driven by their own will, be able to tell me what their options are for their end-of-life care, what they want and why, and what they don't want. And so I'm assessing that throughout any visit, any interaction I have with people. Really, in lots of my practice, I would say. Does that answer your question? In the definition, we talked about this person is pursuing MAID relative to their already anticipated death. And that's just reinforcing the prognosis of 6 months or less. And then self-ingestion. We talked about that a bit, that you have to be able to self-ingest here in Colorado and throughout the United States. You have to be able to get that medicine into your body, into your GI tract specifically. And you have to be a resident of Colorado, which is interestingly defined with some pretty broad terms. So if you have somebody that lives outside of Colorado but is able to maybe come here and get a lease, they're able to show you, for example, be the attending physician, the lease that they've signed. Great, you're now a resident of Colorado. Other states don't have a residency requirement, and other states require 1 year of paid electrical bills at the address in this state and the proven lease, and blah, blah, blah. Colorado is pretty liberal in how we are able to define resident. So here we get rolling up the sleeves. All right, so we've already talked about the patient, right? Obviously the patient's pretty required, and how the eligibility works here in Colorado. And then we have 2 different physicians. I would keep saying physicians.
That's okay.
And I want to acknowledge and forgive, please. So I say physician, but really what I want to say is clinician or provider, because here in Colorado, like I said, you can have a physician or a nurse practitioner be able to serve in this role. So you have the attending, and then you have the consulting, which we'll go through exactly what these roles are in a moment. You also have to have a compounding pharmacist, because the medicines, as we'll learn in a moment, are not something that you go to Walgreens to pick up, but you have to actually have a compounding pharmacist that really knows what they're doing and is willing to participate. So these are all things that you have to have as you pursue medical aid and dying.
Question.
Answer.
If the attending provider agrees, the consulting provider disagrees, what happens?
Good question.
Good question, sorry. If the attending provider and the consulting provider disagree, you have some options. It really is, and I've had this situation happen to me before as a consulting, when I've served as a consulting physician where I don't really agree with the person's prognosis, for example. I have to say to the attending, I'm sorry, I am not able to qualify this person for medical aid and dying, because all of the, ideally, I'm going to answer you in the way that I hope people do in terms of best practices. All of these evaluations, these clinical evaluations, should be independent. So even if they're on the same day, fine. Same location, fine. As long as they're independent assessments. So in my best clinical judgment, for example, this person I had a few months ago with a colleague of mine that I very much adore and admire, he asked me to consult, and I could not serve for that person's, as that person's consulting physician. So I did my assessment, and the person's prognosis for me was well outside of the 6 months or less window, meaning I thought they had a much longer prognosis than the 6 months or less. So I just had to say to the attending, I'm sorry, I'm not able to serve, to write off this person's eligibility. So then the attending or the patient, ideally in collaboration, will maybe go and find another consulting physician. That's what I've seen happen before, but I would hope that no one participating in this would ever feel pressured, to make a judgment that isn't their own sound clinical mind. Yeah. Good question.
Thank you.
Thank you. Also, in Colorado, like every other state, with one exception, I'll go into that in a moment, we also have the option and really the need to involve a licensed behavioral health or psychology professional. If any physician or clinician involved is concerned about the person's cognitive capacity, about the person's level of coercion, if we think other people are maybe pulling some strings, if we have any concerns that maybe this person's actively, acutely depressed and that's why they're pursuing this, anything that we have any concerns about, we are obligated to, by law, and I think certainly clinically it's the right thing to do, is engage with a licensed clinical social worker or a psychologist to say, hey, can you weigh in and help us determine this person's capacity? Can you help us make sure this person isn't being coerced? Can you help us assess, is it the active acute depression that is causing, driving this request? I have actually never had in 8 years, ever had to call this into play. And some states are getting rid of this requirement. Hawaii, interestingly, requires that anyone pursuing medical aid in dying go through a psychological evaluation. But that's the only state that requires that. And when I go to these national conferences and talk to doctors from other states that do this work, it seems like other people's experiences has been similar to mine, where really when people are pursuing this, it's not that they're depressed. It's not depression. Yes, they're sad. They have a terminal illness. They're sad. They're going to be leaving their loved ones. They're stressed because death is hard on so many levels. But they're not depressed. They're actually empowered by their ability to pursue MAID. And I found patients time and again that maybe they were really down about their disease and the road ahead, knowing what their life was going to be. But then when they found out that MAID was available here in Colorado, it's like they got, oddly, like a lease on life, where they got to, I remember one patient, her husband, the woman, the wife of the patient, would describe him as just a curmudgeon, just like a stick in the mud, no matter what, he was pissed at everything and everyone for years. And he had multiple really complex health issues, really terrible diabetes, and all the terrible things that come with terrible diabetes, bad kidney disease, on dialysis, horrible wounds, couldn't lay in bed comfortably because he's always laying on some sort of awful wound, had to get up, 3 days a week to get to dialysis. He hated his life. In and out of the hospital for different wound infections, one complication after another. When he finally learned, he Googled one night, his wife woke up that morning and he said, guess what I found out? And he's like smiling. And she's like, what? Like, what is this? I don't recognize this face. And the way that she tells the stories, he just was beaming. Like, I could do this thing. We have this here in Colorado. And thankfully, he was actually at the time a part of a health institution that allowed him to pursue this and supported his wish. And this gentleman chose the day a few weeks in advance, a few weeks from then. He, put some messages out to friends. They had a parade of people, literally an actual parade on their street of people coming by, loved ones, people from high school. This guy was 74 at the time. People from high school came out of the woodwork, came to visit, and it meant so much. And it was like, as his wife will say, it was like he was a different person. He was back. My husband was back. My kid's father was back. And so I share his story, and I'm thankful to him and his family for allowing me to do that. But to say that oftentimes people do feel this sense of empowerment, this sense of engagement in life again in a way that maybe because of their serious illness or terminal condition, they didn't have that autonomy. They didn't have the breath that they once knew to be their own. And the idea of pursuing a death that was right for them gave them that. So, I always encourage people that are pursuing medical aid in dying or exploring any aspect of their end-of-life care to please involve your trusted loved ones. It doesn't have to be your family. For a lot of people, family, not trusted loved ones. But build, if you can, one person, two people, just some version of support that can really help you walk through the experience. Ideally, again, we engage with a hospice care team. We talked about an end-of-life doula. I guess I didn't really talk too much about it, but an end-of-life doula, much like the birthing doula, is going to come alongside the person who's going to be delivering her child. The doula, at the end of life, is going to really build a relationship with the person who's dying. Get to know what their values are, get to know what matters to them, and really try to help curate, if you will, a dying experience that really honors who this person is. And also maybe serves as an advocate, particularly in families that maybe aren't supportive of the person's wish. So doulas are just, it's an out-of-pocket expense, and you'll find that most of this care, unfortunately, is. But that doula role can really be just, again, an additional layer of support. They're not clinical, so they do not have any sort of clinical training. I am a doctor, so I have some clinical training, I hope. But the doulas, by definition, don't have clinical training. But they do add such a huge layer of support and compassion to make that end-of-life process better for the patient and their loved ones. I also encourage folks, and within your hospice team, you're going to have a hospice chaplain. I encourage people, regardless of how they identify with any sort of religion or spirituality, maybe they're devoutly religious, maybe they're devoutly agnostic, maybe they're somewhere in between. What I have found and learned, again, having learned so much from the individuals I get to work with, that end-of-life work can be spiritual. You don't have to have any sort of affiliation with a religion or spirituality, but just the process of approaching death, the process of allowing yourself to consider, reflect, and contemplate on what your life has been, what you want your death to be, how you feel about your loved ones. There's a lot of spirituality inherently in that. And so maybe engaging with a spiritual provider could really help work some things out that maybe, for example, not a single doctor, nurse, social worker would ever figure out. And I think of a lady I used to work with, an inpatient hospice, and this woman was a devout Methodist. She was very, very, very into her Methodist religion and loved it. And she was dying, she had bad heart failure, and we had she's an inpatient hospice unit where you can do an inpatient hospice, just a lot more aggressive, comfort-focused care. And this lady's on like all of these big guns for comfort. And man, there wasn't anything we could do to get her comfortable. She was so uncomfortable. We truly optimized every single aspect of what we knew to do in the medical team, with our nurse, with our another physician. We had like all these minds there. And this lady, we had a chaplain at the facility who was Baptist. She would not see him because she's Methodist, and she would not see him. And there's her own history there, I'm sure. But Bud, she would not see Bud, the chaplain. And I don't know if it was just she was exhausted by trying so hard to get comfortable or what, but one day she did let Bud in. And again, this is after 2 weeks at that point of very aggressive, comfort-focused care that was just not doing it. And she sat down, our Bud sat down with her, and next day, or overnight, that night, she didn't really need all those pain medicines, the breathing medicines that we were giving her, all those huge high doses of things, she didn't ask for any of that overnight. And we get to the morning meeting the next day, and Bud shares with us that they had this incredible visit the day before, where she had shared a very real, terrifying childhood fear that she had had from her mom, who had told her whole life, especially as a child, that she's going to hell. And so this poor woman was so terrified, and it didn't matter what medicines we could give her. She had fears and anxieties and existential suffering beyond any medication I could ever offer. But there was the chaplain who was able to go in, sit with her, listen to her, let her be heard, that really, truly let her pain and anxiety and breathing just get better. And she died a few days later very peacefully. So that's my plug for spiritual care. I'll say one more plug for now. Maybe I'll have more later. But I really, really do think that death touches so many aspects of our lives. And maybe, for a lot of people, when we're going through serious illness or watching someone we love go through serious illness, it's so clinical. It's so focused on the next doctor's visit. It's so focused on what's going to happen in the hospital. It's so focused on the treatment. But let's look at the person. And with medicine, we don't do that very well. I'm going to call that out. I don't think it's a surprise to anyone. And so I always encourage people to consider engaging with music therapy, art therapy, pets, animals. I think for a lot of people, animals can be an amazing conduit to love in maybe ways that humans aren't. But music therapy, so my technically stepdad died last June after a horrible less than 6 months of a very acute onset of a brain tumor. Fine one day, great, awesome, doing great. He was a GI doctor, literally doing colonoscopies. The next day, fell, massive brain tumor, horrible decline over less than 6 months, dead. This amazing doctor, brilliant mind, would not address death. He had a terminal condition. The moment it was diagnosed, it was terminal. He had the type of brain tumor from which no one survives. And he hit every single run of complication on the ladder of potential complications. It was terrible. But he would not acknowledge that he was dying. He would not acknowledge that he was going to die. Period. He wouldn't talk about it. He was not spiritual. He wouldn't engage with someone spiritual. He would be the last person in the world to ever consider talking to somebody about anything. Because he doesn't need to talk to anybody. He's fine. But man, if we would play certain music, certain songs, he just, I mean, you could physically watch his body, which had been, typically very tense and taut, all related to his disease, just melt away. And I share that because, to be fair, it was not a music therapist, and I don't want to minimize the role of true music therapist, but I say that because we never know what's going to touch someone. We never know what's going to touch us. So be open, and if you yourself or someone that you love or are caring for is really struggling with some very difficult thing like facing their death, try music, try art, try animals, try non-traditional routes, just to be able to help that person feel like a person again. You'll notice, obviously, that the hospice criteria for admission is 6 months or less, as well as MAID. So if you're someone that, someone said, hey, I think you should be on hospice, and you want to consider end-of-life options, use that as like a trigger. Like, oh, well, they said I was eligible for hospice. Maybe I should assess whether or not I'm eligible for MAID. I don't want to make a promise that just because you're eligible for hospice means you're eligible for MAID. It's, again, very case-by-case, very clinical, independent assessment by your clinicians. But generally speaking, if you've been told your prognosis is 6 months or less, please consider enrolling in hospice. And if you're interested in your end-of-life options, please go ahead and start exploring those. So the process, you're going to have to identify and establish 2 different clinicians who are willing to be a part of your care. You're gonna have the attending and the consulting. So the attending is gonna be the one that actually writes the prescription, and you meet with that attending twice. The attending is also the person that's gonna receive the necessary formal requests, which we'll go over in a moment. The consulting provider is really the second opinion, for lack of a better term. I think we're used to that in medicine, so I just say it's second opinion. But again, that's an independent assessment. Kind of like that example we talked about when I had a patient earlier this year that I didn't agree with the prognosis. I had to independently assess that person's eligibility. And you typically are going to visit with the consulting person one time. Depending on the situation, depending on your interests, depending on your clinical needs, depending on the provider's availability, these folks can or may serve as bedside support for you on the day of your ingestion, but there's nothing in the law that requires that you have any sort of medical person there. We'll go into a little bit some scenarios in which you really do want to have someone there, but certainly it's something that if you feel like it might be important for you to have, either the attending or the consulting person there, talk to them about it. And they may talk to you about it as well, I hope.
Question.
Yes.
If you're an attending provider or a consulting provider, do you have to have legal status in some way to be identified as a consulting provider or an attending provider? Do you have a licensure or?
So as long as you have, so the question, I think, and please correct me if I'm wrong, but I think the question is, as an attending or a consulting, do you have to have a specific legal status to be able to serve in those roles? Is that fair?
Yes, thank you.
Thank you. So the answer is no. As long as you have your medical license is up to date, and you have, especially if you're the prescriber, your DEA, your Drug Enforcement Administration license, meaning you can prescribe controlled substances, then you can support that person. As long as you're licensed in the state, for obviously Colorado, where you're practicing MAID. All right, so we have 3 requests that people have to give. 2 of them are verbal, so you have to actually say, I want to be able to use medication. You know, I mean, I'm not saying you to say these exact words, but you need to relate to the attending provider, bless you, that this is your request on your own. You're not being coerced. No one's pushing you into this. This is you driving your choices. And those 2 requests have to be made 7 days apart. It used to be 15, but it's now 7, with the exception that if the attending and or consulting is concerned that, hey, I am really worried this person's not going to live for 7 days, or we're going to get to the point at 7 days and they're not going to be able to do this because they are declining so rapidly, which does happen, unfortunately, then we can actually waive the 7-day period and allow for someone to make their second request to the attending within 48 hours. The written request is actually the patient saying that this is what they want, they're acting on their own. That written request is signed by the patient. It's also witnessed. It does not need to be notarized, but it is witnessed. The important thing is that the witnesses are not people that are going to benefit from the person's death, meaning it can't be a beneficiary to your life insurance policy, for example, your inheritance, that kind of stuff. This is really to protect you, and again, kind of safeguards with coercion. So oftentimes in the hospital setting, I've had patients or just ask someone in the elevator, hey, will you sign this? Which always feels a little icky to me, but it happens more than you want to know. But oftentimes it's ideally like neighbors or friends. Again, so those are 3 independent assessments, twice with the attending and once with the consulting. And I will say that it's possible that if someone meets with their attending and then, let's say it's 7 days, sometimes it's longer, if that person in that period loses their capacity, then the process doesn't get to go on. So it's not that, oh, they qualified in the beginning and we'll just push it through. It's no, they have to, at every encounter, be able to show that capacity to make their own decisions. And again, we talked about the mental health assessment. So the person's gonna first make their oral request to the attending, and then they're gonna ideally wait 7 days, or it can be waived, like we know. And then in that time period, they can go ahead and give the written request to the attending. They can also ideally meet with the consulting provider to get the second opinion, and then they can also, after 7 days, do their second oral request during their second visit with the attending. Once all of that is done and the attending and the consulting agree that yes, this person's eligible for medical aid in dying, then the prescription can be sent to the compounding pharmacy. I always encourage the people that I work with to only ever get the medicines when they know that they've chosen their day. Like, don't just like, oh, I got the prescription and I'm gonna go fill the medicines and then have horribly lethal medications that are absolutely gonna kill people sitting in your home. Like, please, please, please fill these prescriptions only when you know, okay, I've chosen August 17th will be my day, and on August 16th, I will get the prescription. Quick note about planning. Please, please, please plan, and we'll get into that in a little bit. But when I say things like, oh, wait to get the prescription, what I don't want is for someone to think that they can just pick up the prescription anytime. Always be talking with the pharmacy to make sure that the prescription is available and ready for when you are choosing to self-ingest.
Question.
Yes.
What happens if you become incommunicado in this process, where you started it and you had capacity and you could communicate, but then maybe you have a massive stroke or whatever, then it's over, right?
Yeah, unfortunately. So the question is, what happens if during the process you lose the capacity or lose the ability to be able to move forward with the process? When that happens, unfortunately, nature has taken its course, and the person's not going to be able to demonstrate capacity that's necessary. The person's likely not going to be able to self-ingest, for example, like any of the things that are required to be able to actively participate. If the person loses those abilities, they're not going to be able to access the medicines.
Thank you.
Does hospice or Medicare pay for the medications?
Good question. Medication costs, no. And we'll get into that in a moment, in a little bit. But yes, hospice does not pay for the medications and Medicare does not pay for the medications. No federal dollars can go towards anything related to medical aid in dying. And hospice pays, or Medicare pays for hospice and Medicare pays for Medicare, or federal funds. So this goes back to the question someone asked, who can make the MAID request? And it's only the person who is living with a terminal illness that wants this for themselves that can make that request. So this can't be done from a living will, a surrogate, power of attorney, nothing. It's only the person who's actively facing their terminal illness. So, I'll let you all read this question and tell me the answer.
No.
Oh, yes, you guys are the best. No, only the terminally ill person can make this request. So what would be an end-of-life option available to somebody living with dementia? Any thoughts?
You can refuse medical care.
Yes. Yeah, you can refuse medical care. There are dementia directives, so advanced directives specifically focused on individuals living with dementia, which ideally you would fill out and complete prior to the dementia becoming more severe. Ideally, it's something that's completed in the earlier stages so that you have your fullest mind possible to be able to direct the care that you want in the future. With the little asterisk caveat that I love the spirit behind the dementia directives, and in clinical practice, it's often not seen or heard or listened to or honored. That does not mean I don't want you to complete them. I do. And I want you to talk to your families about the care you do or do not want. I want you to do all of those things, especially talking to your family and documenting everything. But just, I don't want to make like a promise that, oh, just fill this form out and your wishes will be honored. So easy. It doesn't happen that way, unfortunately, yet. Maybe someday. Really, the option that's available to people living with dementia when they're in their earlier stages of dementia and still have cognitive capacity to do this for themselves is VSED. So people who have been told, formally diagnosed with dementia, and maybe they're in the earlier stages, and they say, look, I saw what happened to my mom, I saw my sister, I saw my dad, I do not want this for myself. And typically, we'll say Alzheimer's, because that is the most common form of dementia in the United States. Typically, it's about 7 to 10 years from the time of diagnosis to death. And certainly, I've seen longer. And I think a lot of us understand that as dementia gets worse, it's pretty devastating. And for a lot of people, they say, I don't want that. It's the last thing I want for myself. So instead of living out those next 7 to 10 years, they can choose to say, I'm going to forego all liquid, fluids, hydration, nutrition, nothing, so that I can expedite my own death, maybe by 10 years, which is incredibly hard. Incredibly hard. So Visa is the option that we have for individuals living with dementia. They do need to start this process when they still have the capacity to be able to say, no, really, I want this. But it's not just an easy process.
So they have to say it, they can't put it on their most form.
Right. So there are directives out there. So like the state of New York has one. Washington State also, I believe, has one where you can have a visa directed into life wish. What I have seen and heard play out is that that's not honored. So yes, there are directives that exist, but it's very hard either for family, certainly, but also particularly for people that are living in a facility, to say, okay, we're going to withhold from this person now. So really, it's making sure that the person's able to initiate that process on their own. Yeah.
Susan, you listed ketamine therapy
Yes.
in your bio. Are you using ketamine during the 6-month hospice period?
Yes, I'll do it during the 6-month hospice period, but also anyone facing a serious illness. So it doesn't have to be.
Yeah, I understand the prior, but how does it fit into this decision-making process? How are you seeing ketamine play a role in this 6-month process?
More or less around anything with medical aid in dying, I would say, but more around existential stress, existential suffering. When people are really struggling with facing their illness, facing their death, maybe processing a lot of times past traumas. Unfortunately, for a lot of people, especially in older generations that didn't grow up with the opportunity to use therapy and go to therapy, have very real experiences held trapped in their bodies, and by offering ketamine, they're able to kind of break through some of those deeply, deeply, deeply buried tragedies and traumas to try to help create an end-of-life process free of the burden that their body has been carrying, holding on to for all of those years.
Are you finding that either the consulting or attending physicians have any objection to the ketamine by way of interfering with the capacity to make a decision?
Great question. No, I mean, so really with ketamine, anyone that I do ketamine with has to have capacity in approaching ketamine, period, absolutely. And it's so short acting, so I can have someone be on ketamine like this afternoon and tomorrow talk to me about medical aid in dying. As long as they really, the capacity is going to regain. Like I wouldn't ask them to talk about medical aid dying while they're on ketamine at all. It's really more focusing on past traumas, and the ketamine is unrelated for me, for the patients I work with, to medical aid in dying, so as not to cloud any sort of concern for capacity. Good question. So this is one of the biggest burdens that we see throughout the country, and really I would say in Colorado it's pretty significant. The reason I started my own practice for this work is I had so many people, really friends and colleagues, knew that I offered this to patients I work with, and I said, hey, I got this person, can you help them? And hey, I got this person, and hey, they can't find, their oncologist said no, their cardiologist said they won't, could you work with them? And it happened so many times that it became very clear that we don't have a lot of physicians in Colorado that participate with medical aid in dying. They're also baked into the law, no obligation to participate whatsoever. People's interest in this, physicians and other medical clinicians' interest in this may be very sincere, and they may very much want to help, but they work for an institution or employer that doesn't allow them to. And so that happens a lot. That's actually probably something I see a lot, bless you, where in Colorado we have a lot of very large health institutions that really govern like the clinical practice of medicine nowadays, which really impacts the delivery of care and services, and medical aid in dying is one of them. So if you're working with a doctor that says, I am sorry, I can't support you, whether they personally don't want to, and that's okay too, absolutely, or they work for an institution that doesn't allow them to, they should say, but I have this other person you can work with, or here's a referral to this thing. That doesn't often happen. That is what should happen, period. Doesn't often happen. So please don't hesitate to advocate for yourself, advocate for your loved ones if you feel like this is really honoring who they are. And say, look, we gotta help us find someone else. Okay. Ideally, in an ideal world, the person, the attending physician, the consulting physician, providers is someone who you've known forever. Your doctor for years, or the cancer doctor that saw you through, the duration of your initial diagnosis all the way through this terminal phase. That doesn't happen anymore. Unfortunately, I think very few people really get to have those long-standing relationships with their physicians anymore, which is really heartbreaking, I think. But I do like to say that ideally, this is with a doctor that you do know well and that you have a relationship with, as opposed to someone like me who just, hey, we're meeting for the first time, let's talk about death. That said, I love talking about death because I get to learn about your life. But that's the thing, I get to learn about life, what makes you shine, what brings you joy. I want to learn about that, so that I can help you have a death that's right for you. So, let's see.
Is there a list of providers in the state?
Yes, there is. We'll get you that very shortly. So I do want to also name, this is a big driver behind, thankfully, the inclusion of nurse practitioners here in Colorado, is just access. So I mean, rural access to any sort of medical care is really hard. I'm from Kentucky originally. Talk about rural disparities, North Carolina, Appalachia. I lived for 5 years, rural disparities. I mean, disparity is very real in the medical world, and access to care simply based off of where you live can be really challenging for any part of your care, not to mention medical aid in dying. That said, a lot of providers like myself, I do telehealth, I do video visits. I also have a van that I can camp in and drive to where you are and stay in my van, take care of you. This is this is meant to be care delivered where you are. So there are options out there, and the compounding pharmacies will FedEx oftentimes or overnight the medications. So here's a list how you can find participating providers. These are all QR codes, which may not be helpful right now, I'm realizing. But on the End of Life Options website, there is a list of providers. There's also a national group called the Academy of Aid in Dying Medicine. They also have a data bank of physicians that participate. And then the Rocky Mountain is me, and I'd be happy to help you find clinicians that can support you.
You said Academy of Dying?
Yes, Academy of Aid in Dying. Excuse me. Okay, so going into the self-ingestion, we said earlier this is not a pill. I had patients over the years like, oh, just give me the pill, I just want the pill. Oh, sorry, it's not a pill. It's actually 5 different medications. They're all going to be delivered in powder form, which is why you need the compounding pharmacy. And they're given in this little brown bottle that's typically, ideally, about 2 ounces. The bottle itself is a 2-ounce bottle generally, sometimes 4. And all the powder is in the bottle when it's given to the patient or the person picking it up for the patient. Right before ingestion, liquid is added to that bottle. And it's shaken like crazy, vigorous, shake, 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 shake. Mix it all together right before ingestion. was I going to say? Sorry. Again, we've talked about this at length, but in the United States, you have to self-ingest, and that can be anywhere along the GI tract. So orally, through a feeding tube that's already in place, so you can't like go and get a feeding tube to be able to do this. You have to have the feeding tube already in place, or rectally as well. And you want to ingest, ideally, those 2 ounces, sometimes 4, but 2 to 4, in 2 minutes or less. And the reason for that is these medications, go back, these are so potent. And I don't want anyone that's familiar with any one of these medications to see one of the medicines that they may know well, maybe you can take personally on this list and think, oh my God, I'm taking a lethal medication. The dosing of these medications when used for medical aid in dying is so profound that even if you took one of these medications at the dose that just one of these were prescribed for aid in dying, it would most likely cause your death. The dosing on here is so outrageously above anything that we would ever use in medicine. Even if someone is on very high dose opioids, for example, no high dose opioid is ever going to come close to the dosing that we have here for aid in dying. And the medications that are used, that are chosen, and the dosing has all been studied by what we talked about before moments ago, the Academy of Aid in Dying Medicine. They are kind of the clearinghouse for all of the information regarding aid in dying deaths. And we're able to send information to them. They analyze and assess what medications are working, how much, what's not working, and they really are able to do, through evidence-based, a very clear recommendation for the regimen that's used. And this is right now in the nation, it has been for about 2 years. That's, I think, the recommended medication regimen. But the reason you want to take 2 ounces in 2 minutes or less is because these medicines are so potent. You could take a little, you don't want to sip this, and then fall asleep. And then be asleep. And then that's going to be the sleep that you're likely not going to ever wake up from. And you can either have a very prolonged death, or really, I think that's really the most significant concern is the very prolonged death, which can be really upsetting to you or loved ones more than anyone else because you're asleep. But you really want to be able to ingest the medications so that the medicines have the time, have the ability to work all together as they're intended to in that very short period of time. So what if you can't self-ingest? Again, anywhere along the GI tract in the United States we can use. I mentioned it before, we don't have to have, there's no law that says you have to have a clinician present at bedside when you ingest. What I would say is, if you're using a feeding tube, and absolutely with a rectal tube, you're going to want a medical professional there to help with that process. And you're going to want a medical professional there who knows how to handle particularly rectal tubes, but obviously a feeding tube too, just to make sure there aren't any complications for you and obviously for your loved ones at the bedside. I put this on here, so eye gaze technology is used for people that have typically neuroprogressive disorders, so ALS is the most common. ALS patients in Colorado were some of the biggest drivers behind the passage of the Colorado End of Life Options Act in 2016, particularly because generally speaking, they're able to maintain their personhood, their cognitive abilities, but their body has failed them. So their mind is there, but their body is not. And for a lot of people living with ALS, that's a devastating situation. They're locked in the way in their bodies. And so it was that population particularly that was very, very much advocating for the passage of this bill in 2016. But unfortunately, as a result of their disease process, the ALS, you often lose the ability to coordinate your muscles. That's part of the disease. And so the ability to swallow or self-ingest can become really difficult for ALS patients. There has been an eye gaze device developed by an engineer. It's not readily available in the broader medical field, but it is available. is out there, I would say. So if anybody knows of people that have ALS or a neuroprogressive disorder, and they're considering aging and dying, but are afraid they won't be able to swallow or are already using eye gaze, just you can let them know to reach out to me, for example, because this device could be helpful for them. Time. Thank you. 3 okay. We're doing it. All right. Thank you. Okay. I'm trying to sum up here so we can get to our panel discussion. So others can support. So like I mentioned, mixing and like putting liquid into the bottle and mixing, shaking vigorously. Other people can do that. The thing that the patient has to do on their own is actually do the ingestion. So I can hand, if it were my loved one, I can hand the bottle to my loved one, but my loved one, the patient, has to be able to actually put the medication into their GI tract on their own. So as we talk about like preparing for this day of self-ingestion, that's the day that you're dying, okay? For lack of a better term, this is the day of your death. So I say the day of self-ingestion, it sounds more clinical, but it's the day that you're gonna die. So think about, what do you want that to look like? Reflect on the timing of it, the location. You want to practice. First, a lot of the patients I work with, unfortunately, 2 ounces, being able to swallow 2 ounces can actually be very, very hard. It actually causes a lot of people a lot of distress that they're not going to be able to actually get those 2 ounces in. So we have them practice. They practice swallowing 2 ounces of liquid. And really making sure that everything that you're doing and the people around you are doing is honoring you throughout the experience of it all. So as you think about, you want to think about who you want there, who you don't want there. Really, I think these are all incredibly intimate and personal decisions. I will say with regards to pets know, pets always know. Pets know when people are dying, whether it's made or death of their own disease process. Pets know. Think about the people you want, their roles you want them to play. Who's going to help you mix it? Who's going to put the playlist on? Who's going to keep the kids away or not? Do you want to have a celebration of life that day? Do you want to have a living funeral, which is now, again, more and more understood, that, celebrating you while you're here. Like that's what this woman that I mentioned, the guy and her husband, the curmudgeon, she said it was great. We got to have a funeral before he died. He got to hear it. He got to hear all this stuff about him. It was amazing. She says it with such a smile. And she's talking about her husband that she loves and has lost and is sad. But she talks about his death with such joy because they got to really see what love can be.
If somebody is dying in a power chair, somebody needs to know how to work the power chair once they're gone.
Yes.
Very practical terms.
Yeah, so that's actually a great thought. In terms of roles and who you want there, who knows how to work the things, the devices, the tools in the home. For example, as Aurora mentioned, a power chair. That's a real thing. Power beds. Make sure you have people there that really know how to work these devices. The clinicians behind the scene, the attending, the consulting, they're going to be collaborating. Hopefully they're engaging with your hospice team as well. I always communicate personally with the compounding pharmacist to make sure, like, hey, this is my concern for this person, make sure this is happening, great, whatever. And again, that constant reassessment of decisional capacity, so that we're making sure that we're maintaining the integrity of the law, that this is for people that have the ability, the capacity to make these decisions for themselves. In the law, you don't have to tell anybody that you're doing this. We encourage you to tell your hospice team. We encourage you to tell the providers that are participating in your MAID process, for example, so that they can help you and your loved ones prepare. I also just want to reinforce that with your death certificate, nothing about MAID is mentioned. So you don't have to tell people, and you certainly don't have to tell, in terms of like your own community, you don't have to tell anyone if you don't want to. I do think the more you're able to talk about it openly, about death, period, and the fact that you're dying, the better their grief is going to be. Not that they won't have grief, not that they won't have stress and sadness, but the more you can talk about it together and grieve together, the better people will be able to handle your death after you're gone. And I don't have an evidence base for this, but just purely from seeing it, the people who talk openly about their death have a more peaceful death. It doesn't matter if it's MAID or VSED or they're dying of their disease process without anything else. people who talk about their death openly and grieve openly with their loved ones seem to have a more peaceful dying experience. So think about where you want to be. The reality is, in facilities, people who live in facilities may hit some very real roadblocks and barriers to being able to utilize medical aid in dying. You might want to consider your home, for example, or if you have a loved one whose home you could use, that's great too. I also really want to do a big shout out. Eric is here today, but so a lot of people, I mean, I know for myself, if I were to ever have to like really imagine my death, what I would want it to be, man, if I could be on a mountaintop, surrounded by nature, because that's where my love is outside in nature. And if I could experience this deeply, I think, spiritual process of death outside, surrounded by the people I love, could you imagine? In some beautiful place. That's me, and I don't want to put my wishes on anyone else. But Beautifully Made actually is an organization, unlike any in the United States, that we have here in Colorado, that's able to help people find locations where they can actually choose to ingest and have their death day outside in nature, or maybe at a beautiful home, vacation rental, where they can have all of their family there, and they can make truly that death and dying experience so profoundly personal. And so Beautifully Made, you'll see the QR code here, but really that's a matter of curating this individual's death in a way that is beautiful for that individual. Ultimately, absolutely do not ever take this in public. That's something that I tell by law and clinically speaking, don't ever take this in public. I've never had a person do that, but please don't. Been over that a lot. I always encourage people to consider their loved ones, ideally a doula, your hospice team, if they can participate. We talked about the role of providers in your day of ingestion experience, particularly if you're using the rectal or feeding tube administration. Please have a clinical person there to help facilitate anything that could go wrong. And also, like, up until the moment, you can have everything set up. You could have the most beautiful situation, go on a mountaintop, like birds are out, I mean, the family's there, everyone's with music, everything's perfect. You have the medicine in your hand, it's been vigorously mixed, it's great. And you say, no, it's not, I'm not gonna do it. Okay, no problem, you do not have to. You're not obligated ever to do this, ever. So, right before self-ingestion, about 30 minutes, an hour, you're gonna take some medication that helps with nausea, because of course the last thing you would want is to take the medicine and throw it up. So pre-medication helps keep the medicine down. After you take it, within 5 to 10 minutes, oftentimes much less, you're deeply asleep. Asleep from which you're not going to wake up. And then, generally speaking, 2 hours or less, you die.
Only one ingestion?
Yes, with that 2 ounce. Yeah. There's lots of things I can tell you about the bitterness of it and what we do to mitigate the bitterness. I won't get into all of that right now for the sake of the talk. But please, when you are ever considering this, make sure you're with a provider that's willing to go through all of the details of what to expect to help you and your loved ones prepare. Because like everything else in life, the more we prepare, I think the less anxiety-provoking it might be, and hopefully the more empowered we can feel going into the experience. So we talked about health insurance. Because no federal funding can be used towards medical aid in dying, these are the very real federal prohibitions. And the reality is commercial insurance oftentimes follows whatever Medicare is doing regardless. So generally speaking, commercial insurances don't really cover this, with the exception here in Colorado. Kaiser Permanente does support with their medical visits as well as discounts on medications. Also, Denver Health in Denver serves folks around the state that allows, they don't use federal funding, they have their own foundation specific for medical aid in dying that allows them to support individuals accessing the medications as well as the clinical visits.
I think End of Life Options also has a...
Yeah, I was thinking that too. So yeah, so these are just, I'll just put this big blurb up here about what to think about when you're looking at the finances of all of this. These are some of the things we've talked about. where the cost might be. Medications have a range depending on the pharmacy that you're using, generally between $450 and about $1,100. The providers, it's a very huge range across the state. So just remember, you're going to have to see you have three different clinical visits. Some people charge like in a package fashion. Some people charge an hourly rate. Some people charge per consultation fee. So really have open conversations. And if your providers are not being open with you about the finances, go to someone else, because these are things that you should be able to talk about openly and freely, and you have every right to know transparently what you're looking at here. Doulas, the prices vary dramatically. Here's a list of potential doulas throughout Colorado, and the Colorado End-of-Life Options, or End-of-Life Options Colorado, does have a patient assistance fund that can help with the cost of medications, and donations are very much appreciated. It's how we can help support people throughout our state access this rate who may otherwise not be able to afford the medicines. So I just want to remind everybody, MAID is just one of the tools that we have for those considering their end-of-life options. Just one. It's not the only way to have a peaceful, dignified death. In my own personal practice and my professional opinion, but certainly personally, I cannot tell you what is meaningful. I cannot tell you what is a personal death for you. I can't tell you what a lovely death would be, what a beautiful death would be for you. These are such intimate and personal choices that you really deserve to talk about this with your loved ones, with your family, with the people that know you best. Talk about it with someone like me that loves hearing about you. But really making sure that you know that whatever your death needs to be for you, we hope it can be. And also, not everyone who goes through the whole process, has the medication, has everything ready, chooses to use it, and that's okay. That's completely okay. The process sometimes can be hard to find participating providers. Hopefully that's getting better now in Colorado, but as soon as you're starting to think about it, go ahead and just connect with End-of-Life Options Colorado. Go ahead and really start talking about it with your loved ones so that you're not waiting till the last minute and then you're like trying to push all this in under the radar. I want to give a huge thanks to everyone here, the Levada Village here in town, the Sangre de Cristo Community Care and Compassionate Choices national organization, as well as Death with Dignity. Both those last two are advocacy organizations that support access to end-of-life options throughout the country. I really want to thank the Levada, it was gorgeous coming here today, the library for hosting us. I really appreciate that. And John, thank you for getting that ball rolling. And really all of you, really truly. We wouldn't be here without your interest and your willingness to participate. This is my contact information. You'll see there as well the information for End-of-Life Options Colorado. I also have some resources here that we talked about throughout the presentation. And if you need me to go back to the other slides, I can.
Please.
Oh, sure. Anybody else need me to stand here for a moment?
Go back to the
Oh, okay. There we go. And I'm going to stop talking now, which is a gift for everyone. And I'd love to open up tomorrow.
Thank you. So for anyone who's interested, we have a couple of local folks who are experts, and Dr. Wilboy will stick around too, and it'll be more freeform. Thank you all for ignoring this. Please just raise your hands if you have a question. It's much easier. I was instructed to do that. I never loved that idea. Can I get our experts to come up? Nobody sends Stephanie. Here, look, we have chairs for you right here. Or, can I get to sit in the doctor chair? Sorry. Oh, look, and they're getting to know each other. So
we know each other.
Oh, you do, okay. I know, I like this. Very
This is
small.
just, I was thinking like there was going to be 5 or 6 of us. And
No, it's good. And then you know where to follow up. Additionally, there is some information over here, and we'll stick around as we can afterwards if you have questions. questions that don't get answered. So, hi, my name is Aurora Hunt. I'm a nurse practitioner. Delighted that I now have the option to prescribe. I have spent most of my career in acute care, primarily ERs, more recently hospice, palliative care, and home care. Trying to undo those 40 years of working in an ER and being like, yes, you have to live! Because now I realize living isn't always the best option, and that it's kind of an individual choice. And as someone who believes in autonomy for humans, I'm all for that. So with us, we have Dr. Susan Wilhoit, you may or may not know. I'm going to skip you for a minute, skip over to Stephanie. Stephanie works with Sangre de Cristo Community, which is both a home care and your local hospice agency. So she's our hospice ringer. She comes from a background also in acute care, like so many people who are interested in end of life do, and is fairly recently from the area.
We moved in December.
Okay, so
Pediatric nursing for 21 years.
right, and in an ER too, so very familiar with the ER.
Yes.
And acute care side of it, and I love this, ooh, that means something, has 3 children and loves her chickens, is the way it reads. I like that. I thought you might love your children too, but you didn't specify on that. If you'd like to rectify, feel free. No. And Elise Engelby, who is like a human Swiss Army knife, she comes to us with a background in gerontology and kinesiology. Sorry, it's just weird. No one has done as many things as she has. Has worked in a mortuary for 4 years, so if you have questions around actual death practices, it may be helpful. Is a volunteer at 11th Hour doing vigils for people who are dying and companioning them. And also now runs Levita Village, the local assisted living community, so brings a wealth of experience to the panel. So to start off with, I'm going to ask my question, which is, when you're on this side of things, you often don't know how things work, or I feel like there are things that we have information about that are surprising for people who don't work in the business. So if you can all just take a minute or two and mention something surprising about end of life that people probably don't know off the top of their heads because they don't do this for a living. Who would like to start? That was a dirty trick.
Honestly, I'm not really sure. I've only been doing this since January. Although I've done a lot of death and dying in pediatrics also. But I think there is a worse place than being dead. And that's in a body and in a mind and a spirit that is not ready to be alive anymore and not able to make those decisions for people. So I encourage my patients that if they've ever thought about it, that we can start the process very early, because I've had 2 patients that didn't make it through the process. And so I would definitely recommend starting early, and that it is, there's worse places than being dead.
Definitely. My thought on that is that you don't get to pick your death sometimes, but today educated me that maybe you do. And so from my experiences and what I've learned in watching people die literally in front of me and holding my father as he took his last breath, that there is that other side. And that when I felt the impression of my mother and my sister sitting at our bed, and I could feel their weight on my feet, and they had just previously dying right before him. So I had the death of my grandmother, I got married, and the death of my sister, the death of my mother, and the death of my father, all within a 3.5 year period. I'm going, wow, death is amazing, and there's nothing to be afraid of.
Do you want to answer?
I would say something that would maybe should not surprise me, but does surprise me, is how hard it is to die in our healthcare system and in our society. And please understand, I am so grateful for the amazing advancements we have in medical sciences and what we can do with medical sciences. And I also think that medical science would really benefit from just kind of a little humility check, because it's hard to die, and it's hard to die at home. It's hard to die where you live. It's hard to die where you want to be, because you inevitably have to be taken into the hospital. And there's lots of rules around that and reasons for that-ish, but the rules aren't logical. They're made by institutions and people and C-suites, no offense if anyone here is a C-suite person. But the best way I know to combat that is to talk to your family, talk to your family, talk to your family, be open, be honest, talk about the death that you want for yourself, and find people, if it's not your family, find people that will help advocate for the death that you want.
That's a super great lead in to, I just have to say something, which is, yes, and have paperwork to back up what you say. As you said, you know, some things hold better than others, and discussing with your family and also your medical providers. Oftentimes, you going to your doctor and saying, or your nurse practitioner, and saying, hey, you know, I'd like to talk about this, and give them the opportunity to talk with you. Oftentimes, they're willing but haven't really been trained, so having the paperwork is helpful. To build off what you said, one of my favorite statistics is, you know, I think when you ask people how they would like to die, everyone says, you know, in my sleep, and when I'm totally well. But there is, this is my favorite. Well, wouldn't you? I mean, come on. Or skydiving. There actually is research that kind of characterizes what Susan was saying, which is our medicine has gotten so good that people don't die suddenly anymore. So in the olden days, you know, you lived, you died in childbirth, you lived, you died of a heart attack, and that's not the way we die now. We die in a much more attenuated way, and there are many more choices to make decisions about what quality of life is for you and how long you want to stay on the training force. So it's not this, it winds up, and I'm sure a lot of you have had this experience with your loved ones too, but it tends to be kind of a long journey. And again, there are many exit points that may or may not be intuitive to you or your healthcare provider. So just talking about it with everybody is a great thing, and having people who know what you want is super important. One of the things I wondered about, particularly with this panel that's pretty broad ranging, is if you are considering something for yourself or for your loved ones or parents, you know, how do you begin to have that conversation? Or let's talk about other people. How do you move the conversation to meaningfulness? How do you switch the conversation from, you know, let's treat to maybe this is the precious time, you know, what do we want to consider? So any advice you have for people in terms of talking about things like this with loved ones or strangers, anyone?
I think one of the greatest joys I get to do as a doctor is asking people where they find joy. And that's how I would start the question is, I'd love to hear, what lights you up? What brings you joy? What's making your life really shine right now? And in their answer, I get to understand what they really care about. So it might be a gentleman that I saw several years ago in my palliative care clinic. Man, this guy, he lit up talking about his garden. If he could just get to his garden, that's where he shines. That's what brings him joy, is working in his garden. I said, oh, well, what are you growing now? What's out there? What do you have? I said, oh, well, I haven't been able to go out this year. And the garden is about 20 feet from his back door, and he had very bad COPD, and breathing was just intolerable to make those 20 feet to his garden. And being able to talk with him about, all right, what can we do to help with that breathing so we can get you out to your garden? And being able to make the kind of adjustments in medications, for example, that allowed him to get out there and return to what joy was for him, really helped me learn how to see the person and not the disease, I guess. and I'm realizing I'm not answering your question very well. But I would say, really, by starting off with where do you find joy? Where, like mom, like my own mom, I would love to know, like, what's making your life, like, great right now? All right, are there any barriers to that? Like, what's getting in the way of that? And if it's, oh, I have to go to the doctor every day for this appointment and that appointment, well, what if we backed off on going to the doctor all the time? If it's getting in the way of what brings you joy, maybe we make some adjustments. So I guess the answer I would have right now is starting off with what brings you joy, letting that person gush about that, and figuring out if there's things standing in the way of that, and if there's changes that we can make to better support their joy.
For me, I would say the conversation would start with asking the person what legacy do they want to leave. Those were good conversations to have. What was important about your life? What do you want to leave your grandchildren, your children? What do you want to be remembered for? And what things were important to you so that you could pass that on to the next generation. That was always important to me, especially after I didn't know several grand elders who I lost before I was even born. And I don't have that history of them. I only have history of 2, and 1 died very young, so I really only have a history of 1. And so my legacy and the family generation it just is cut off after that. So if I can't pass that on to my children, then what's left to be remembered of that legacy and of that life? And so the conversation for me is writing that stuff down, getting your grandchildren, getting your children to tape record you, to do that generational history of who you are, what you left, what you did, what your joy was, what you lived for, what your passion was, and to let that be remembered for your family. So I would have that conversation with your family.
Well, as a hospice nurse, my patients are often dying, so my conversation with my patients revolves around what makes them happy and what are they not able to do right now. We start with those things and we make those things happen. If you want to do something, I'm going to make it happen for you. It might not look like you expected it to. You might have to take a wheelchair, we might have to make safety considerations. But what is important to you, what makes you happy, and getting to know that person. And then after we build a relationship, we're able to more openly talk about the death and dying experience, what we want, and those days leading up to the medication. And right now there's still a conversation going on that there is a 6-month date coming, and that is a date that was set by somebody else, and you do not have to take the medicine on that day. So you still get to make all these decisions. You are still living, and if you're still living on that day, we will continue to live. So giving them the power to make those decisions and feel comfortable and talking about them. And a lot of times the patients aren't comfortable talking in front of their loved ones. So a lot of times these are conversations I have when the loved one's gone. And then we bring up to the loved one, and a lot of times my patient just isn't my patient, it's my family.
It's a teeny bit awkward, I could just shout.
Yeah, those are great answers, and I see the commonality of start with joy and love, build a relationship before you walk in there and go, do you want to take some aid in dying or what? Or, yeah, and I guess as an extension, because you're all in the business in different ways, you know, what is the best way to advocate for your loved ones or for yourself if you want to pursue something that isn't kind of traditional mainstream medicine or maybe in opposition to what your provider is suggesting? Do you have tips for advocating? What you like to hear when people come to you about things, or what you would recommend people use in approaching subjects?
After I build a relationship with my patients,
Feel free to raise your questions if you have.
after I build a relationship with my patients, depending on what's going on with each and every one, because everybody's very different. One of my patients in particular brought up death and dying to me. I knew nothing about it. Now, after I build up that relationship, depending on who the patient is, how I know them, how comfortable I feel, who's around, I will let them know in our hospice book on page 49, there is a little insert about death and dying, and then just educate them on that And then if they want to start that process, you just make the decision. It's just a yes or no decision for you. And then once you make that decision, we'll work out all the kinks later.
It could also be just a question about advocating for people in general. I mean, I think you were very honest that the system is not perfect. And, you know, some people come in, and other people are too timid to say anything. You know, is there anything you can suggest to empower people to consider that their decision-making is important? Anything you use?
From my experience, I would say definitely I liked what the doctor said about the live funerals, having their own funeral. And from my experience with funerals, it's very difficult when you have a family member come in and not know what your wishes are. So I am truly, after working in the funeral industry, an advocate for pre-planned funerals and the 5 wishes. Because you have to put those wishes down. Because truly, from my experience, you don't know how you're going to die. You may have the ability to choose made, and that would be fabulous. But can you? Do you? Do you really know what terminal illness you may get? Or if you even, or you're going to die in a car accident tomorrow. So I mean, the reality of facing the death when I literally would be talking to somebody and then a week later, I get the notice that they died. And the shock of that is traumatizing, because you do learn to take life one day at a time, and you learn to realize how precious it is. So if you have the option to decide how you're going to die, that those papers are so important, and that you have your life celebration while you're still living and not dead.
I will say I want to acknowledge it is so hard, I think, for most people, most of us, to advocate for ourselves in the medical world. And I think that's not okay. That's not how it should be. But that's been my experience as a patient. That's been my experience as a daughter of a terminally ill person. That's been my experience in trying to have my physician colleagues talk about death with their patients who are dying. So I want to first name that I think being able to advocate is actually really hard and so important. And I think that the most, I don't have any good advice, I really don't, I don't want to act like I do, but I would say don't be shy. This is your life, this is your moments that you have. If you're not getting the answers that you're needing or the conversations that you're needing, speak up to that. And I know for a lot of us, we're very uncomfortable speaking up sometimes for ourselves. I can advocate for other people all day long. I'm terrible at advocating for myself. I will totally name that. I think it's okay for you to say, look, I know how busy you are. I know that really we're here today to talk about my blood pressure, but honestly, more than my blood pressure, I really want to spend our time together today talking about what is my medical situation and how can you help me understand what's going on with my body so that I can make the choices that are right for me in the context of my real medical situation. Because I think with forms like this, I've seen so many times they're handed out to people. These forms are about conversations. These forms are meant to be done in concert, in collaboration with the clinician that knows you, that knows your history, that knows you well, so that the choices that you make and you put on there, the checkboxes that you have, actually reflect not just you, but really what is the reality of your medical situation. So I think really having conversations with your providers, but being able to say, look, I know, I don't care what you need me to tell you right now in terms of why we're here today. Yes, it's blood pressure, but I'm really gonna ask that we table the blood pressure. I'll come back, I really will. I really wanna talk about blank today. But I think it's a matter of acknowledging that you are worth it. Your life is worth it. And again, I think for a lot of people it can be really hard to do that advocacy internally. But please know that you are worth it, and please don't hesitate to advocate for yourself.
Bluntly, sometimes you have to train them, and when you begin to engage them in these obviously easy slam dunk for you, you're like, yes, that was the right question. But for a lot of providers, I think they may want to talk to you, but they've been trained not to talk about death. The other thing I would say as someone who meets people who are often close to dying, people generally know, so trust your own instincts too. If it feels to you like things are not what you're hearing, or that they may be more dire than your doctor is saying, particularly your oncologist, I'm not calling anyone out here, it's fair to say, it's fair to talk to other people, because this is really precious time and you want to have as much of it as you can. You guys are really quiet out there in New York. Oh, good. Yes?
I have a question, because of an experience I had with my mother, that you mentioned how we have sort of a different kind of trajectory because of the drugs that are given, the pharmaceuticals and the treatments that are given to people who have conditions that it sort of peters out in a way instead of having a
Organ failure
kind of
and
thing.
failure to thrive.
Yeah. My experience was that when my mother got on hospice, there were a number of medications that the physician or attending physician had already given her. And then hospice continued to add to that because of her comfort and because they thought that perhaps this would help. But my experience was that once she was taking off all of those drugs and advocating for that, for the lack of pharmaceuticals, that she was put on hospice, and they gave her 2 weeks, and then she lived for 3 years on hospice.
Yeah.
Prognosis, I don't know if you all heard that, but just, yeah.
So I think it's really important not only to advocate for a person in their death, but also, everybody's kind of standing around expecting people to die because they're on these unbelievably incompatible drugs. And how do we help a person who is, elderly or close to death, be able to get off of medications that are not helping in either way?
Get them on hospice.
Yeah.
Get them on hospice.
Yeah, and the whole thing about that is you see 99-year-old, 70-pound failure to thrive ladies, they're like, okay, let's put her on hospice. They take her for all her meds and she completely rebounds and it's for another 3 years.
That was her mother.
That was what happened.
Yeah. Oh, yeah.
That's my patient. Those are my patients. You get them on hospice, they get comfortable, we
Right,
discontinue
you
some meds.
focus on quality of care.
Focus on a better quality of life for the time they have remaining, and we work on that every visit, every day. What are you doing different to increase that life that you want to have until that very end?
And I would say for people who are nowhere near having a prognosis of 6 months or less and qualifying for hospice, the principle of what I'm hearing is still true, that whenever you're placed on a medication or whenever they want to do a test or a lab or diagnostic something, always feel comfortable asking, how is this going to change my future? How is it going to change the management? How is this going to impact my quality of life? Oftentimes if you go to the cardiologist, they want your blood pressure to be this. And if you go to the kidney doctor, the nephrologist wants your blood pressure to be this. But then your PCP, who's managing all of that, wants your blood pressure to be this. And so then you have all these different doctors, possibly, maybe, sometimes not always necessarily communicating or reading one another's notes. And then you're on 4 different blood pressure medicines, and next thing you know, you're in the ER because you passed out because your blood pressure is so low. So always feel comfortable, empowered to ask, how is this going to impact blank? My quality of life, my energy level, my bowels. Always do not hesitate to ask. So whenever you're being offered a new medication, say, how is this going to interact with my other medications? Is this going to cause more side effects? And you don't have to be accusatory or, I try to counsel my own mother this all the time. You're not being adversarial. You're advocating for yourself. And that's okay. And I think you have to do that. Otherwise, you do end up on a ton of other medications. Polypharmacy, the technical term for it, is a very real reason why people end up in the ER and hospitalized all the time. Polypharmacy, being on multiple medications that cross-interfere with each other and cause more and more complications. So ask. That's what I would say, ask.
Then we had more medications.
Thank you very much. I so appreciate what you're saying. This is incredible because hearing from medical professional this truth is really, it's like a breath of fresh air. Thank you.
And I also think that especially the elders, they kind of tend to think, well, these are the doctors. And
But you have to take it because the doctor
That's the
said.
best thought, because they trust, and we really shouldn't trust.
Well, on our end, excuse me for interrupting.
Yeah, please do.
Coming from the generation of when I was young, and I was taking my father to a well-known physician here locally, and I was very young, I was just starting to take care of my elderly parents, and my father in that generation still said, you know, don't tell the doctor what to do, the doctor said this, and I'm like, no, you need to advocate for yourself. He's not living with you every day, he's not seeing what I'm seeing, he's looking at a chart, this is the measure on, you have side effects, Dad, we can do our own research, we can find out. So he's not God, you know, and when I had to say that to a well-known doctor here in town who dearly love, she's right. I mean, it's a breath of fresh air. And as a physician, I'm asking you, educate your fellow physicians that they have to advocate, that people are educatable. They know. They're not stupid.
Physicians are hard to educate.
We have Google.
Healthcare workers in general are hard to educate because people have bias. And in the ER, I'm going to save your life. And that's
One way or
going
another.
to, yes, one way or another. And we're going to add medications to the already medications you're taking. But it's not until you get into a spot where your diagnosis changes and your life trajectory changes that you can start looking at what you have left and what is really needed to give you that time and that
Quality of life.
We are out of time. We'll stick around as we can. If people have questions, I would like to thank everybody for coming. You're all death emissaries. Your willingness just to hear us talk about these things lightens the mood in the entire world, because we are all going to get there one day. So I appreciate your willingness to play. Our fabulous panel, thank you all for coming. The town of La Vega, our fabulous librarian, Sarah, who made the cookies. And again, we have the information and some advanced care planning documents up here that are free if anyone would like to talk about or fill them out. Thanks so much for coming.
Thank you so much.
Thank you.
Thank you.
Thanks for hosting. Oh, thank you so much.
So I kind of